I am Dr. DeAun Nelson, a naturopathic physician practicing weight-independent healthcare in Portland, Oregon. I invite medical professionals to listen as I discuss how shifting the focus off of weight in healthcare can greatly improve health outcomes for patients of all sizes. I will explore what it means to practice in a weight-inclusive paradigm and discuss tools to implement these ideas in practice. Keep in mind that the information I will present may be new to many of my listeners and may sound radical to some, but stick with me. This information could change the lives of your patients. For this episode, I was fortunate enough to be able to talk to Dr. Jennifer Gaudiani. She is an internist, a certified eating disorder specialist, and she is the founder and medical director of the Gaudiani Clinic. She's board certified in internal medicine and completed her undergraduate degree at Harvard Medical School, at Boston University School of Medicine, and her internal medicine residency and chief residency at Yale. After 8 years at Acute Center for Eating Disorders, she left as its medical director to found the Gaudiani Clinic, which provides in-person and nationwide telemedicine outpatient medical care to patients of all genders with eating disorders and disordered eating, and to those in recovery. The Gaudiani Clinic is a health at every size informed provider and embraces treating people of all shapes and sizes. Dr. Gaudiani's first book, Sick Enough, A Guide to the Medical Complications of Eating Disorders, was released by Routledge in October 2018. I have been reading this book and I was thrilled to be able to talk about eating disorders, weight stigma, and health at every size with Dr. Gaudiani. She talked about how physicians can be more aware of eating disorders that present in a variety of bodies, and she also talks about her experience as an internist with patients who are experiencing eating disorders. I was thrilled to get a chance to discuss this very important topic with her. Now, on to the interview. So I am welcoming Dr. Gaudiani to the podcast today. I am so excited to talk with you today. I've been reading Sick Enough, your new book that is just out, and it is about eating disorders. And it has been an amazing book. I'm really excited to read it, and I hope that anybody who works with people reads it, because you never know what you might be running into. So I wanted to start out with just having an idea of kind of how you got into like eating disorders, and then really how you got into the health at every size idea, and looking at eating disorders from a really different approach.
Thank you so much for having me, DeAun. It's amazing to be here. I'm so grateful. My story is that I am an internal medicine doctor, not a mental health professional with zero nutritional training. And I was trained in a really Western medical system. On the positive side, I was an English major in college who focused on close reading poetry. So that maybe gave my brain some protective skills from the subsequent Western medical training I received. But I really just luckily got into eating disorders when my husband and I moved to Denver about 11 years ago. And I helped to run a medical inpatient unit for critically ill patients with anorexia nervosa, doing medical stabilization as part of a multidisciplinary team. And with a family member who was affected, and being a woman in this society and being a citizen of this society,
Right.
I was deeply connected to the idea of helping people understand what was happening to their bodies as a result of disordered eating and eating disorders. So, I found over time that I was missing something in my hospital setting. As it turns out, I was missing so much more than I even thought I was missing. So very, 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 very much more. But it was, the setting that it was. And I realized that I wanted to have longer term relationships with my patients than 2 weeks, falling in love with them in the hospital, and then off they would go to eating disorder programs. I really wanted to see a much more diverse set of patients, a more diverse set of bodies, and to understand better how the medical consequences of eating disorders were affecting people in their everyday lives when they weren't showing up at the highest level of care in the country with a particular type of eating disorder. So I started my own outpatient clinic in 2016, the Gaudiani Clinic, and I found a totally kick-ass bunch of women to help me grow it and help challenge me and educate me, and for us to support each other in running this clinic, which, there doesn't exist one quite like this anywhere in the country. I realized that we had the opportunity to do things differently in a really interesting way. We could kind of bust the patriarchy. We could
Nice.
challenge certain hierarchical um, framed norms of who has an eating disorder and what does that look like medically, and how does recovery progress, and it's just been like incredibly exciting. So we start out with certain values in our clinic that specifically, tries to serve people of all genders, body shapes, sizes, and ages, and all types of eating disorders and disordered eating from around the country, because we have a lot of telemedicine licenses.
Oh,
Um,
nice.
yeah, which is so great. And we start out from what tries to be a non-assumptive approach, where rather than imagining that I know what my patient wants for their body, I start by saying, so that I'm not assumptive, could you please tell me what your goals and values are? And that's going to be the compass by which we take our medical work.
Which is something that really should be happening regardless of who your patient is and what they have, right?
It should
Or
be
what they're dealing with.
universal. That's right. And I
Yeah.
try to begin from a place of standing in my privilege as a white, cis, hetero, thin, able-bodied, highly educated female, and understand that I'm not representative of many of my patients. And when I speak, when I lecture, I recognize I'm not representative of many of the wonderful clinicians who are in an audience. But what I'll try to resolve to do is use my privilege to center voices that have been marginalized, and to bring the power of my credentials, such as they are, such as society respects them, to give voice to the much better science and the much, much better compassion behind movements like HAES.
That's awesome. That's awesome.
I
I'm so
came to
glad you're
HAES.
doing this work.
Oh, thank you so much. I was going to say I came to HAES late. I say
Mhm.
with a little bit of mortification. I really didn't know about health at every size or the weight inclusive movement until I began my clinic. And it was by the grace of a number of really brilliant, generous teachers who kindly gave me their patience and their wisdom, like Carmen Cool and Hilary Canavy, Lindo Bacon, Desiree Adaway. These are all people who have either indirectly or directly mentored me and taught me. Deb Berghardt is another really important one.
Oh, yeah.
The many, many things I didn't know because I had it wrong. DeAun, I had it so wrong. Even as an eating disorder professional, I had it
Oh,
wrong.
yeah.
Even as somebody who was like liberal and thoughtful, I had it wrong. And I
Oh, yeah.
did harm. So I've come to understand that that medical professionals, for the most part, I'm not even going to say for the most part, medical professionals are an oppressor class to patients in larger bodies.
Absolutely.
So I'm one of them.
Yeah.
And that means that I have to continually notice and respond to my own internalized size stigma and where that's going to lead me wrong as far as engagement or diagnosis or treatment. And boy, do I continue to make mistakes, but I'm deeply, deeply dedicated to keeping getting better.
Yes, absolutely. I mean, I've talked about this on the podcast numerous times, that, we are doing harm. And I know that that can cause a lot of people to feel very uncomfortable and very upset because we go into medicine, regardless of what flavor you pick, we go into medicine to help people, and to be told that we're doing harm is hard. It's hard to hear that, and to think about all of the people that you have hurt in the past. And I always tell providers, and try to reinforce it on this podcast, is that once you know better, you can do better.
Yeah.
And the harm that you've done is done. And all of us, not just in this, around size, but I mean, all of us have done harm because we didn't know something, or we were new, or I mean, there's so many ways, but we're all doing our best as well, hopefully, right?
That's
And
absolutely
doing your
right.
best means learning more and doing better once you know more, and then trying to forgive yourself for the harm that you've done, and say, I didn't know. And then if you know and are continuing to do harm, it's a very different thing. But
Well, and
I feel like,
how can we also forgive ourselves provider frailty and
uh-huh,
not accept it? How can we say, yeah, this hurts and I'm a perfectionist because that's why I went into this field in the first place. I wanted to help and it really hurts me when I cause harm. Oh no, I'm not going to I'm not going to engage in frailty excuses. I'm going to take a deep breath and say,
mhm.
let me do better.
Yeah,
I
like,
will do better.
exactly, it's done, and not from now on, I'm going to keep going and do
Yeah.
better. I always liken it to, I don't know why this always comes up for me, is talking about like the thalidomide, right? We didn't know, I mean, the medical world, um in general, didn't know what was happening, although some people did. And as soon as we figured out that thalidomide was causing significant harm, well, it took a little longer than immediately, but people stopped, like, doctor stopped prescribing it. And that doesn't negate the harm that was done to those children and those families, but it also prevented it from continuing, right? Then, rather than just sticking our fingers in our ears and saying, "Blah, blah, blah, it's fine, it's fine, it's fine, let's keep doing this," right?
Yeah.
And there are so many things throughout medical history that are like that. And I think
Mm.
that weight and weight stigma is going to be one of those things in the future where we will be just astonished that anybody thought that it was an issue. And I hope to live to see that day.
Me too.
So, okay, so let's talk about your book for a minute, or maybe the rest of the interview. I uh, I was telling you earlier that I haven't quite finished reading it yet, but I highly recommend reading it. I'm about halfway through, and then I've read a couple of the later chapters as well. And I think you've done such a great job of expressing stories, but then also really getting into the meat of taking care of medically fragile patients, and then really, I feel like, busting some myths that maybe people who aren't in the eating disorder world might assume about the body and about starving bodies. I really enjoyed the fact that, no, I guess not enjoyed, but I appreciated the fact that you actually went very step by step through what is happening when a body's starving, because I don't remember learning that in medical school, like sitting down and saying this is what happens when somebody's starving.
I never learned either.
Yeah. And I feel like that's a problem, and especially in our diet culture, I think that potentially a lot more people are semi-starving or starving than we realize, who aren't officially anorectic uh, or bulimic, or they don't have an official diagnosis, but they're just on the verge of starving every day. And so I guess I think it would be interesting if you could kind of do an overview. I mean, everybody should read the book if they want more information, but do a quick overview of maybe uh, what starvation in a patient looks like, and or even semi-starvation, and what might be presenting when somebody comes in. Maybe they've been restricting their calories pretty severely for a long time, or less severely, but also for a long time. And yeah, if that's something that you can answer succinctly.
Yeah, I would love to. So I wrote Sick Enough, a guide to the medical complications of eating disorders, because I'm so lucky to have this decade-long experience taking care of the medical aspects of people with eating disorders. And what I find is that there aren't that many medical providers who have that expertise because we never got any in our training. And so I thought, I want to make sure this is out in the hands of providers and also of patients and families. I wrote it with an eye towards all three groups because I want to empower all three and improve the level of medical care of people with disordered eating and eating disorders of diverse bodies wherever possible.
Right, because we do have a very often limited idea of what an eating disorder body looks like.
That's right.
For
The
sure.
reality is that it is the significant minority of patients who fit the constructed stereotype of an eating disorder that is thin, white, cis, straight, visibly malnourished and affluent and young and able. Well, that's the body type that gets attention in the media because it is not coincidentally the body type that is worshipped and that is held out as the optimal body. They represent the vast minority of patients with eating disorders. That means that the vast majority of individuals with eating disorders are in a wide variety of bodies.
Mm-hmm.
And they come in all colors and ages. They have all sexual orientations and gender presentations. This is a very diverse group of people. The problem is, well, there's so many problems, is that Western medicine has been taught in such a way that we make those people invisible in the medical office. And by invisible, I mean the system itself may preclude sharing such a tender, difficult, whole heartfelt reality as, hey, doc, I think I have an eating disorder.
Mm-hmm.
If we only have 8 minutes with a patient, that may not come up. And also, when we look at somebody as Western medical practitioners, we may have, we almost invariably jump to conclusions about their health just based on the size and shape of their body, which is
Right.
absolutely scientifically incorrect.
Right.
I have so many patients, DeAun, who tell me in the midst of their eating disorder, because I only see patients with disordered eating and eating disorders, they may be in the midst of anorexia nervosa where they are restricting calories, they are exercising, they are miserable, they are medically malnourished, and yet they present in a larger body and their physician takes a look at them and suggests a diet. Or maybe they
Yeah.
even started that behavior because a physician, in all the power that a medical provider holds, recommended a diet. How can it be that medical practitioners are recommending the very behaviors that we understand as disordered and dangerous in someone in a smaller body? What is this double standard?
Yeah, I wish I could answer that because that is the big question, right?
Mm.
Um, it's the fat phobia, but yeah, I often wonder that. Like, doesn't it make sense that that's not going to work?
It's a dreadful problem.
Oh
There
yeah.
are, however, some physical manifestations to think about in the office that practitioners listening to this podcast can be aware of, and individuals who experience these discriminations and this poor care can hopefully find validating personally as well. So, regardless of body shape and size, there are certain ways in which our physiology changes when we starve. I'm going to use the word starve to describe any situation in which, for more than a couple of days, our bodies are exposed to inadequate energy intake compared with energy output of our bodies. And I say a few days because everyone's going to get the GI bug once in a while and have
Right.
the vomits and some diarrhea.
Right. And our body is used to that. I mean, our bodies
Yeah.
can handle that really well. Yeah.
Yeah, that's right. That's right. For the most part, that's manageable. What I like to go back to with my patients is the concept of the cave person brain. And that's about as neurobiological as I'm going to get because I almost didn't pass neurobiology in med school. The cave person brain, I think of as the part of our brain that runs us as a mammal. It's the part of our brain that has evolved to exquisitely respond to starvation in our environment. And it's why the human species survived, because as we were going through our generations of evolution, we were for the most part in a resource low environment when it came to food. So our brains had to really evolve to do some magnificent work to save our lives when we didn't have enough food. Therefore, when someone has disordered eating, such as, for instance, engaging in quote unquote, big quote unquote, clean eating, or the whole whatever it is these days, the whole
Uh,
30 or
yeah.
paleo or low carb diets or whatever it is, or if someone has an eating disorder, which might be classic restriction of calories or restriction of food types, or it might be restriction all day long until the evening, at which point your body is so famished that you ravenously eat food, or it might be somebody who's on a cleanse. Diet culture is indistinguishable from disordered eating and eating disorders as far as your cave person brain is concerned. All it understands is that its mammal isn't getting enough food. And so it says very kindly, I'll take care of you. I'll help. It's so good to us. And what it does is, in ways that are predictable but individual based on each person's genetic makeup, it might do one or more of the following things. It might make the person chilly because great deal of our energy intake goes towards keeping us at 98.6 degrees consistently. And when we're not getting in enough calories, the brain says, oh, I'm not going to be responsible with my limited budget of calories to keep you warm. I'm going to
Right.
make you feel chilly so you go out and seek sweaters and hot cups of tea. I'm going to cut the blood flow to your distal extremities, to your hands and feet, so that they're chilly all the time because those aren't necessary for life. I'm not going to waste energy on warm blood going through hands that's just going to evaporate
Right.
into the air.
Exactly. We can jettison those if we need to. Yeah.
Exactly, not necessary for survival. It might slow people's digestion so that as they eat not enough, they find that when they do eat a reasonable meal, their belly feels uncomfortable, full, bloated, and they think, ooh, well, there's a new intuition that tells
Mm,
me I'm not supposed to eat this. So I'd better go back to whatever I was restricting. It
right.
might cause constipation for the same reason. Your body doesn't want to waste a calorie on a wriggle of the viscera. It might cause fatigue because when we go into nutritional hibernation, like a bear in winter, if bears didn't sleep all winter while not eating and drinking, they'd die. So there's this deep sense of fatigue and brain fog and exhaustion that people feel when they're not getting enough of all the nutrients and plenty of calories. People's heart rates slow when they don't eat enough in all body shapes and sizes because at rest, the body is trying to conserve calories and their blood pressure falls as well. But the difference between someone with a low heart rate at rest because of athletic fitness and someone whose heart rate is slow at rest because of inadequate calories is that the one who's starved, when they get up and even just walk across the room and back, their heart rate will change dramatically. It might not formally become tachycardic or faster than 100 beats per minute, but it will change radically because the body knows that these muscles in the skeletal system, as well as the heart itself, are malnourished and deconditioned, even if someone is overexercising. So, a
Right.
really well nourished, well rested athlete might have a slow heart rate at rest, but they will also have a slow heart rate when they walk across the room and back. A starving person in any size body is likely to change their heart rate significantly, perhaps by 50 or 75% or more from sitting to walking. And that's not an orthostatic change. That's not due to blood volume. That's
Mhm.
due to deconditioned, starved physiology. And finally, I would say our sex hormones can go away. If you're not eating enough, your body knows that it's not a safe time to spend calories on sex drive, having sex, getting pregnant, or delivering a baby, or having menstrual blood flow.
Absolutely.
Low testosterone and low estrogen in males and females are both very common. And everyone will reflect some of these differently. But the fact is, these are observable physiologic phenomena that have to do with malnutrition.
When you talked about the hormones, I remember when I was in school, I did um, some. I did the midwifery program as well, and
Mm,
I did a paper in my last year about infertility in larger women. And
mm,
there's always this assumption that larger women are infertile because they are fat, and that if they just lose weight, then they'll be able to have children. And something that I found was a hypothesis at the time. This was like several years ago. That potentially the reason that larger women are actually having problems getting pregnant and ovulating is not necessarily that they are fat, is that they are actually trying to not be fat. So they're dieting and they're not getting enough calories. And
ooh, I
so their
love that.
body, yeah. And so their body, not necessarily shutting down to like pre-puberty levels, but is basically your body's like, okay, like we barely have enough to manage this body, much less create a completely new one.
Mm,
So let's stop with this ovulation thing, because we don't want to take a chance on getting pregnant. And then like we don't really need to spend the extra, we don't need to be losing blood because we can use that. And that is something that you know for me it made complete sense. I was like, of course that makes absolute sense. And
yes.
then after reading your book, I was like, even more sense. Of course that makes sense. And these are not women necessarily who are anorexic, who are not, they're eating, but they're just not eating enough to support their body.
Well, and that's
They're
what's
on a
so
diet,
important.
right?
Yeah, that's what's so important. I feel like you're, bringing forth this point in your podcast really helps bring us all along, because it doesn't matter what the motivation is for the inadequate energy intake. For instance, for elite athletes, we use the relative energy deficiency in sport, or REDS, to describe the multi organ, multi process dysfunction that occurs when someone is incidentally not taking in enough nutrition in order to do their sport of choice. We don't even need to call this by different names. And it's not that anorexia nervosa is sort of they're not the ones who are sick enough, as it were, to get attention for this. Anyone who's getting in inadequate energy consumption is going to experience a variety of physiologic and probably psychological consequences.
Yeah. And I often wonder, um there seems to be, at least in my practice, there seem to be a lot of people with thyroid dysfunction, quote unquote, and hypothyroid. Some of them have autoimmune diseases, but then some of them also are just low in thyroid. And my question there too is, I mean, is that partially because they're not eating enough? And in some cases it's not even that people are trying not to eat enough, it's that they are just, our our society is this strange combo of let's eat tons but don't eat too much.
Mm.
And then we have sort of skewed views of portion sizes, because either you go to a restaurant and you have a gigantic portion size, or you look on the back of a box of something and it's this really tiny portion size.
Yeah.
um and so like we don't even, and of course most of us, I think even people who are actively trying to move out of the diet cycle are really struggling against this river of information and expectation that they've had their entire lives, and now they're trying to reconnect with their body and get enough calories in, but they don't actually know what that feels like anymore. And they don't know what that means. And so are still potentially under eating, maybe not severely, but are under eating. And then, their metabolism is slowing down. And over time, that leads to, hypothyroidism. And, then eventually, they have to be medicated for that. And so I think about these things as well, maybe
Absolutely.
completely unaware, and it's certainly not to an eating disorder extent, but we're all just wandering around not eating enough and not being fueled enough, regardless of our body sizes and our energy levels and all that kind of stuff.
That's absolutely right. My experience with thyroid dysfunction in individuals with eating disorders in diverse body sizes is that when the body is stressed sufficiently by malnutrition in any body size, the thyroid can malfunction, a process called sick euthyroid syndrome, which is often also found in intensive care unit patients whose bodies are also severely stressed, either by a physical trauma or by an infection, for instance. And my experience in this thin biased world is that physicians will see that thyroid dysfunction where the anti-thyroid antibody is not positive, which it is in 95% of cases of true autoimmune hypothyroidism. And they'll put someone on thyroid hormone saying, hey, this will give you more energy, or this sort of subtext or even declared context is this will also help you lose weight,
Right.
which is profoundly harmful.
And then on the flip side of that, I have run into many physicians who will not put people on thyroid who could probably use the support, because maybe their TSH is not quite out of range, although the TSH range is so big, and they're not looking at any other options for any other thyroid hormones necessarily. And they're saying, oh, I'm not going to give you thyroid because you're just wanting it to lose weight, even if the person is presenting with and they're symptomatic and really struggling and could actually potentially use the support. And so there's like that sort of like, I won't give it to you because I want you to try to lose weight on your own, or like you can. Which I always thought was interesting as well. And often when those people are, really looked at a little more carefully and given some thyroid support, even just a little bit, those often have symptoms resolve, and they do feel, a little better and are able to take care of themselves better, feed themselves better, move, do all those things that are more supportive of health.
I don't know those indications as well, because that's a wonderful aspect of your training that I wasn't given. But what I can certainly agree with is that if we can focus on the holistic individual and say one of the reasons you're exhausted is that you haven't eaten carbs in 3 weeks because someone told you that was a good idea, let's reintroduce carbs and give your body a vital nutrient that it needs for muscular energy and brain function. And let's see how you feel. That holistic experience, as well as reminding individuals that their body isn't the problem. They're not the problem. We have to locate the problem outside of the individual within a greater context of socio-political economic forces.
Absolutely. Absolutely. What is the next question that I want to ask you? I'll just throw in my little dietitian questions. They're not little dietitians; they're amazing dietitians. But I was talking to a couple of dietitian friends when I was talking about doing this interview, and one of them because they often have to interact with medical providers trying to get patients that they see as, that are obviously not eating like they know what they're eating, and trying to get providers to evaluate these people medically so that they can, either get higher levels of care or even do outpatient teams to make sure that they are doing well. And one of the questions that one of the dietitians has is, when you're trying to do outpatient treatment, what is the minimum frequency recommended that they see their PCP and have labs done?
That's a great question. And it really varies by the individual, which is not to say I'll dodge it. It just means it's a little bit of a longer answer.
Right.
When I have patients whose medical problems are getting in the way of their eating disorder recovery work. For instance, they might have chronic nausea that hasn't had a cause found. They might have severe bloating and distension and either diarrhea or constipation or both that severely impacts their ability to nourish themselves regularly and take care of themselves. When they have significant purging behaviors that put them at risk of electrolyte abnormalities. And I should say significant should be have a little asterisk placed next to it, because I have patients who purge multiple times a day who never have an abnormal electrolyte. And I
Mm.
have patients who purge very little and get seriously abnormal potassium levels. So, anytime electrolyte abnormalities have been found and are a risk, I think in those groups of patients, as well as those who need intensive monitoring for very abnormal vital signs or a modestly abnormal EKG that needs to be followed, they need to be seen weekly.
Okay.
Um, I think for individuals who start a treatment, for instance, for small intestinal bacterial overgrowth, where it's an annoyance, it's a part of their life they want to help, but they're able to progress with their eating disorder work, and who need to check in and report on a few weeks worth of progress, because you're not going to see week to week progress. Those individuals potentially can be seen once a month. I think ultimately the conversation is between the patient and the physician. And the question is, what would be helpful to you? Would it be helpful for you to see me every 2 weeks and for us to go over how your digestion is doing and how your new medicine from this time is doing? Or would it be helpful for you to see me in a month or a week? Um, I try to stay away from algorithmic medicine to a certain
Right.
extent, because I really love the opportunity, and I have the privilege of doing this in my private practice, of fine tuning the patient experience to the individual.
That's a great answer. um, Something that I ran into with another dietitian, we were talking about a case that she had where she and the therapist were trying to get a higher level of care for a patient. So they sent them into their PCP, and this just may be a comment for me, may not be a question, but the PCP noted in their objective findings that the patient was well nourished.
Oh,
Because I don't know for sure if this physician just this was part of their template and they just forgot. Um, the dietitian did contact the physician and basically say, like, your notes really are going to help make sure that this person can get into higher level care. And the physician was fine with them, like they were encouraging them to do that as well. But that having that in there that says well nourished would cause some problems, right, with insurance companies. And so, like, I was wondering if there are things like that, because I hadn't even thought about that. I mean, I totally should have. But I also haven't been doing I'm still pretty new to it. So I was glad that that came up early. Are there
yeah.
things that, like, when you're doing objective findings, particularly, or questions that you want to make sure that you ask to, so if you either have, like, maybe objective findings that you need to make sure you have down for patients who are looking for higher levels of care, um, or who are actively in an eating disorder, and then also as a second part, uh, things that you want to make sure that you're screening for, just kind of all patients, to make sure that you can uncover potential eating disorders or before they become much worse. Two
Yeah,
part
it's such a
question.
good question. there are a few things to say. One is that in med school and residency, we're taught, as internists at least, to use the general umbrella term well developed, well nourished. And we even abbreviated WDWN, which basically means there's a human sitting in front of me and I never really paid attention to their nutritional status.
Yes.
That's all that means.
Yeah.
But it's a reflex. And that is
Yeah.
a problem because with template medicine, where we click, 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 we may not think about what we're writing. And I think that is where internalized size bias shows, because it's an unconscious click and it's an unconscious bias working together. The other thing to say is that I have patients in all variety of body sizes who may not present with any weight loss at all, whose restrictive eating disorder behaviors make them very medically compromised.
Mhm.
I believe in a narrative form of medicine, and anyone who's ever read my consultation notes knows that they are wordy.
Mine too.
But great, excellent, sister. But I think that the underlying impact of that means that I can't fill in a table that makes more of a statement than I can write in a paragraph in which I advocate for my patients, which is one of the age old jobs of a medical practitioner. And so I might say, this 32-year-old male patient presents with a body weight that looks acceptable by standard medical assessment. However, he is exceptionally medically malnourished. And these are the ways in which I tell that. He's bradycardic. His pulse doubles when he walks down the hall. He has acrocyanosis with icy cold hands and feet. He has very low testosterone levels, showing that his brain has shut off testosterone production. And his GI function is slowed, causing significant GI distress and difficulty improving his caloric intake. And so I use those words to advocate for my patients. We also know that for patients in larger bodies who have lost weight in response to caloric restriction or purging, that the degree of weight loss can correlate with significant medical compromise. A really important paper out of Stanford showed that patients with so-called atypical anorexia nervosa, which is the biased DSM-5
Yes.
label for those who have anorexia nervosa and don't happen to be visibly underweight,
Oh,
that
so
those
frustrating.
individuals, when they present for treatment, the percentage change of their body weight, the greater that percentage, regardless of the presenting BMI, one of the worst measures ever,
Agreed.
leads them to be as medically compromised as somebody who has a very low BMI in the context of chronic anorexia nervosa. So we have to know this, that
Mhm.
these individuals present very ill and they are sick enough to get all of the same care that their narrowly constructed peers with anorexia nervosa receive.
Thank you. Yeah. That's that's so important. One of the things that I loved about your book, and I'm going to encourage again for people to go read it because we can't just read huge passages of it on the podcast. But I really appreciated the ways that you discuss talking to patients about them feeling that they're not sick enough to be in treatment, and things like this, that we make assumptions, patients make assumptions, doctors make assumptions, and to say that yes, actually you are sick enough even if you don't look a certain way, or you don't fit some stereotype. So highly recommend people go read those stories because they're really important.
I really appreciate that. The other thing to say is that even when we do a good screening medical workup, the narrative account, the telling of the story of what's happening in an individual's relationship with food and their body and movement may be the only data one has to know how sick they are. Because in somebody who purely restricts calories, every single lab test is going to be normal, almost invariably. that includes albumin, which we think of as the malnourishment blood test.
Right.
But it turns out that albumin only drops in response to an inflammatory process like rheumatologic disease, autoimmune, malignancy, or infection in somebody, and then causes them to lose weight due to malnutrition. Pure caloric restriction without an underlying disease process leaves the albumin normal. And in fact, somebody might still have a normal pulse and a
Mm-hmm.
normal blood pressure, and yet they might be very significantly ill in their eating disorder.
Mm-hmm.
So, what that individual has is survivor genetics. That is, their body is amazingly resilient in the face of terrible treatment at the hands of a mental illness, as driven by a toxic society that's weight obsessed. So I can do all of the labs. I can do a CBC, I can do a CMP with FOS, I can check a TSH, a vitamin D, OH, and an estradiol or testosterone, which is my sort of standard lab panel. I can do an EKG and vital signs. They may all be normal, as may the person's weight, if I even check their weight, when I try to really rarely check weight unless I'm following weight restoration
Mm-hmm.
actively. So then you have a person who's like, oh, Dr. G, the doctors I've seen have just said I'm not sick. In fact, I look good. In fact, keep up with my healthy diet. And the answer is that's where we have to hold that space for their narrative and say, this person is not getting enough energy
Mm-hmm.
and their GI system isn't working. It's not working in ways that are measurable, but it's not working. And their fundamental experience of their life isn't working. They're not able to live their values and their goals because of their relationship with food and movement. So they are sick enough to get assistance.
Yeah, absolutely. I'm good. I'm looking back at the questions that my friends threw out there. One question was, "What do you believe most doctors miss with eating disorders, besides the eating disorder itself, potentially?"
Mm.
But
I mean, I could write a book about it.
and you
um,
did.
I'll say this. I think what one of the key things that most doctors miss is that diets don't work. They
Amen.
don't work to ameliorate medical problems that patients want to have in better shape. They don't help to improve health. In fact, they almost invariably harm. And I think that's where my health at every size perspective has really been just unbelievably satisfying. As I apply health at every size in a medical model, because we know it works psychologically, it's so
Mm-hmm.
clear it's right psychologically, it's so clear it's right from a nutritional perspective. But I think there's so few medical practitioners who actually use it that there's a reasonable question out there like, what happens? What happens with HAES?
Right.
And the answer is, in my 2 years of experience at least, that in patients of all body sizes who have experienced either binge eating disorder or persistent food intake above their sort of intuitive need, sort of a force feeding model that is promoted online in a way that I think is potentially very dangerous. But a number of patients participate in it because they have nowhere else to go and they've been failed by the medical system. When I apply HAES principles to those patients, who may now have developed type 2 diabetes and steatohepatitis or fatty liver, hypertension, high cholesterol, absence of menstrual period, what I'm saying in a HAES model medically is, let me help you find a dietitian, let me help you find a therapist who are HAES informed and
Mm-hmm.
who are weight inclusive practitioners. And let's help you learn or relearn how to nourish yourself with satisfaction and energy needs and deliciousness paramount throughout the day, not postponing meals, not holding off on any particular food group, but really eating delicious, satisfying food. And let's consider helping you move in ways that are congruent with your ability and interest, and
Mm-hmm.
ultimately pointed towards the values and goals you've established. When I do that with my patients, so far, I have 100% response of unbelievable improvement in medical complications. So patients who were on 300 units of insulin a day are now on 0. Patients who were on 150 units of insulin a day now no longer have diabetes.
Yeah.
Patients who were unable to walk 10 steps are now walking across parking lots and joining their family for dinner in a restaurant. They're playing with their kid. They're swimming in the summer. They're going sledding. They're hiking. And to a person, there is this sense of immense vitality and joy in their body again, even within the toxic society that surrounds them. So that says to me
It
that
works.
HAES works medically.
Absolutely. This is anecdotal, but there was a woman who had not been trying to restrict calories for many years, but was struggling with a lot of health things. And she got this idea that she needed to eat enough. She wasn't sure if she was. So she did count her calories for a little bit just to see where she was. That wasn't triggering for her. And she was actually only eating about 1,800 calories a day, and she was a larger woman. And struggling with a lot of different like sleep issues, exercise intolerance, energy, all of those things. And she decided to start, she kind of figured out an approximate basal metabolic rate ish. It's never perfect. And then she added some calories onto that. So she had a minimum of a certain amount of calories. I won't go into the specifics, but a certain amount of calories per day. And then she tried to add to that whenever she added, exercise to that. So she was trying to go for neutral ish to a little bit over. And she was going to do it for 100 days. And that's all she did was she just started eating more. And she didn't eat anything specific more, just more food. And within that 100 days, her sleep was normalized. She could sleep through the night. Her energy, she was able to do her full day of living. And she was pretty busy, had a family. She was able to meet her very minimal exercise goals that she had wanted to meet, plus went well beyond it. And, it for me, and I read about her years ago. And for me, I always knew intuitively that health at every size was something that was medically very positive and very necessary. And to see somebody actually do this and have such changes, and all she did was eat more. I mean, like that she just fed
It's
herself.
beautiful.
And for me, when I know so many people who fell into HAES and were very confused and I don't know if this will work, and then eventually they like come around. For me, I read the book in school actually, and was like, oh yes, of course. Granted, I am coming from a larger body, and I have had doctors tell me that I had pneumonia because I was fat, and
Oh,
asthma because I was fat. And even as a kid, I was like, do you know anything about pneumonia and asthma? Because I'm 12 and I know that.
mm,
um, but, uh, so I know what it's like to live in a healthy, strong, fat body. And I also, as I've aged, I've had issues come up here and there where I've had to manage them. But, stopping eating or not giving myself the care that I need never helps,
that's right.
ever.
That's right.
And then I also, a lot of what I think about too around the health is with and I brought this up in past episodes. We talked about weight stigma and its effect on stress and cortisol levels, and then the cortisol levels affecting pretty much all the other hormones as well. Because our bodies are ready to save us all the time. And if we feel threatened, which unfortunately a lot of folks in larger bodies feel threatened all the time, also people in minority ethnic groups and gender presentation that's off of what's considered normal. I don't like that word normal, but what's considered quote unquote appropriate in our society, which is ridiculous. Or but anybody who doesn't fit what society considers normal, I look at those things and I see that a lot of those conditions we associate with quote unquote obesity are seen in those groups as well. And so I just remind myself that in the end, maybe we need to not worry about what we're putting in our mouths or, how many steps we're taking every day. Not that those things aren't important to be aware of, but we also need to be able to stand up and say, it's not appropriate to treat people differently or stigmatize them because they don't look like a very narrow, specific idea of what is quote unquote normal.
Absolutely. We have to be advocates.
Yeah.
We have to put ourselves out there and re-educate people to use HAES and to cause less harm as a result.
And I think that's important for all medical providers to try to get on board with that, because that is part of healing your patients and healing yourselves. Because certainly we're all trying to heal ourselves too. I think most of us got into medicine because of, things that we needed to fix or, people that we know who we wanted to help.
Yeah.
And so here's the last question. We're running a little over what I normally do, but I could probably talk to you for hours. I say that to all my guests, and every one of them I meet because you're all amazing. But what are some questions that you don't often get asked in interviews that you think you should be asked, or that you would just like to address something that we haven't addressed and you would like to talk about?
That is a really thought-provoking question. Let me think about it for a moment.
It's okay if you don't come up with anything too.
I think one question is perhaps how can practitioners heal their own relationship with the field of medicine and be less burnt out? And one of the ways is by allowing ourselves, within the variety of contexts in which we work, to engage in the age-old practice of medical providers, which is to bear witness. There are so many times when I have tried all of the tools in the toolbox with my patients, and they're still suffering from their irritable bowel syndrome or from whatever it might be. And in those moments, I understand and try to respect my own anxiety and distress over not being able to fix them or ameliorate their suffering. And I say, I'm going to stay curious and patient. I'm going to keep reading, and I will walk with you on this journey. Unlike your family members who love you so much that it may be hard for them to hear how much you're suffering, you can tell me all of the stuff you're going through, and I will hold that for you in this sacred space. And even if I can't fix it right now, I will bear witness. I think that is healing to us in the pressures that we put on ourselves as practitioners.
I love that. I love that because we do feel like we have to know all the answers all of the time. And something I try to remind myself, and I will actually tell my patients this too. I'm human and I'm doing my best. I'm not perfect. And that I'll keep looking and I'll keep doing my best. And And honestly, I have seen healing changes with my patients just because I'm willing to listen. And I'm fortunate to get extra time to do that. I know not everybody has that opportunity. I wish we all did. I mean, that would be, I think we would have much better outcomes if we had, more than 10 minutes to see patients. I mean, I see my patients for up to an hour.
Nice.
And sometimes that's just, them talking. Sometimes that's me talking and just sort of reassuring them and telling them what I'm seeing, and reflecting back to them how they are coming into the world, or how they're reflecting into the world. And I have been so fortunate to see people just relax. I mean, how many people go to the doctor and relax? And I have seen that happen, and it fills me with hope, because I think that anybody can do that ultimately. And certainly dealing with physical problems is very important, but we are looking at a whole person, and their emotional and mental and even spiritual aspects of their lives, their bodies, affect the physical. And I feel like we've forgotten that sometimes,
Yeah, I agree.
Yeah. And nourishing ourselves, not just with food and not just with movement and sleep, and but nourishing ourselves with connection to other people, to our doctors, to the people we see on the streets. I think that those things, to animals, all those kinds of lovely connections, are so important.
Agreed.
Yeah. Well, thank you so much for showing up. And I always feel like I need to be having second interviews with people just to fill in all the stuff that we want to talk about. But I'm so appreciative that you talked to us today. And I really do recommend everybody go check out the book. You did a really great job. So
Thank you,
congratulations.
DeAun. I really appreciate it.
Thank you again, Dr. Gaudiani, and thank you all for listening. For more information, please head to donoharmconsulting.com. The theme music for the show was composed and performed by Galen Davis. Show art was created by Stacy Bias. If you enjoyed the podcast or learned something new, please subscribe, as it helps amplify this important message. Also, please share with friends and colleagues.